Mr. Chairman, ladies and gentlemen, it's a great honor for an orthopedic anesthesiologist as me to be invited to combine the International Anti-Society of Orthopedic Surgeons, especially for the topic of anticoagulation therapy and its impact on regional anesthesia. Because major orthopedic surgery such as hip fracture surgery or hip or knee replacement potentiate thrombus formation and develop deep vein thrombosis. Furthermore, if a thrombus breaks and migrates to the lung, the fatal complication may be unavoidable. Unfortunately, many clinicians believe that the incidence of venous thromboembolism in Thailand and Southeast Asia is low, so lots of patients undergo surgery without thromboprophylaxis. But in fact, the lifestyle of people in this region has changed. McDonald's, pizza, or KFC are now common in our country. The incidence of asymptomatic and symptomatic deep vein thrombosis or venous thromboembolism after major orthopedic surgery in Asia is also high, similar to several reports from Western countries. This suggests that thromboprophylaxis should be considered in major orthopedic surgery. The last clinical trial demonstrated that aspirin is superior to placebo in preventing deep vein thrombosis after hip fracture or hip or knee replacement. However, other pharmacologic thromboprophylactic regimens are more efficacious. Therefore, the American College of Chest Physicians Consensus Conference of Anticoagulants recommend not use aspirin. Current guidelines recommend prophylactic antithrombotic therapy, such as oral vitamin K antagonist, unfractionated heparin, low molecular weight heparin, or a selective factor 10 inhibitor for all patients undergoing major orthopedic surgery. Besides the thromboprophylaxis regimens, type of anesthesia is also the risk of venous thromboembolism. We can ask our patient to choose either general anesthesia or regional anesthesia or both in combination for major orthopedic surgery. However, neurological regional anesthesia, which is a familiar technique in our region, such as spinal block or epidural block, is generally safe and well tolerated if offer a number of advantages over general anesthesia and is used frequently in major orthopedic surgery. A meta-analysis of 141 studies involving more than 9,000 patients has clearly demonstrated that all outcomes are better with general anesthesia, with regional anesthesia rather than general anesthesia for hip fracture surgery or hip or knee replacement, such as better for vascular event, for bleeding, for infection or other, especially for the deep vein thrombosis is decreased venous thromboembolism up to 40 to 50%. However, epidural or spinal hematoma is possible complication when drug for venous thromboembolism prophylaxis and are used in combination with neonatal regional anesthesia. For the second American Society of Regional Anesthesia Consensus Conference on Neuraxial Anesthesia and Anticoagulation provide a guideline to encourage safe and quality patient care. This guideline is still not revised and cannot guarantee a specific outcome. Within the next year, the next consensus conference should be updated. There is no wholly accepted test, including the bleeding time, which guides antiplatelet therapy. However, NSAIDs alone does not create a level of risk, and it is not a contraindication for neuraxial block. Suggested time interval between discontinuation of drug therapy and neuraxial blockage is variable depending on medication. Patients receiving heparin for greater than 4 days should be a platelet count access prior neuraxial blockage and catheter removal. During subcutaneous or mini-dose prophylaxis, there is no contraindication for neuraxial block. The risk may be reduced by delaying heparin until after block. However, during intravenous prophylaxis, there's a problem. Heparin should be delayed for 1 hour after needle placement and remove catheter 2 to 4 hours after last heparin dose. For the low molecular weight heparin management, in this based on totally daily dose, timing of the first postoperative dose, and dose schedule. Single daily dosing is safer than twice daily dosing. Invariant neuraxial catheter may be safely maintained. However, the catheter should be removed a minimum of 10 to 12 hours after the last dose and 2 to 4 hours after catheter removal. Traumatic needle or catheter placement may increase the risk of spinal hematoma, and recommend to postpone low molecular weight heparin to 24 hours. For the oral vitamin K antagonist, such as warfarin therapy, must be stopped ideally 4 to 5 days prior to planned procedure. And the PTO-INR must be measured prior to initiation of neuraxial blockage. Neuraxial catheter should be removed when INR is lesser than 1.5. There is no definitive recommendation for removal of neuraxial catheter in patients receive fibrinolytic and thrombolytic therapy. In the meantime, the measurement of fibrinogen level may be helpful for decision making. Herbal drugs, which is commonly used in Asia, by themselves have no evidence for mandatory discontinuation prior to neuraxial block. Neuraxial anesthesia for major orthopedic surgery is generally considered safe. However, there is low risk of spinal hematoma. The risks for neurologic dysfunction are estimated to be more than 1 per 100,000 patients. Vascular trauma from needle or catheter placement into the subarachnoid or epidural space can disrupt the epidural venous plexus, producing bleeding. Although this is rare, it is a serious complication because the spinal canal is closed and not expandable. As a result, bleeding into this compress the spinal cord, producing long-term or permanent paralysis. Thromboprophylaxis can be increased the risk of spinal hematoma. In patients receiving and low molecular weight heparin, the report frequently of spinal or epidural hematoma is further greater. The neuraxial regional anesthesia is in the anticoagulant patient is based on approximate timing of needle placement and catheter removal relative to the timing of the anticoagulant drug administration. Familiarity with the pharmacology of hemostasis altering drugs should guide the clinician in management decision. Regional anesthesia can be performed with neuraxial anesthesia such as spinal block and epidural block or peripheral nerve block. Single and continuous peripheral nerve block provide an alternative to neuraxial block without the risk of spinal or epidural hematoma in patients receive anticoagulant therapy for venous thromboembolism prophylaxis. For peripheral nerve block, for anesthesia and postoperative pain control, has led an increased interest and can be performed with surface anatomical landmark technique, peripheral nerve stimulator, and can use ultrasound guide for peripheral nerve block. The risk is further reduced spinal hematoma from peripheral nerve block. However, because of the nerve and vessel relationship, the surface anatomical landmark technique is still take a risk of bleeding related to puncture to vessels, especially when repeated, difficult, traumatic, and bloody puncture happen. For the electrical stimulation is the most commonly used method. As you can see, peripheral nerve stimulator was used to localize nerve before the injection of the local anesthetic in performing peripheral nerve block. Peripheral nerve stimulator produce an electrical current that depolarizes the nerve membrane and cause contraction of efficacious muscle or sensory stimulation of the relevant area. A greater of this confirms the proximity of needle to the nerve. A greater success rate and enhanced safety of the block should be expected with peripheral nerve block. However, the surface landmarks is still the important key of success. Peripheral nerve block for orthopedic surgery are usually performed without visual guidance Adding on surface anatomical landmark and electrical stimulation to localized nerve, it is therefore not surprising that regional anesthesia may fail or accidentally press
the nerve pressures artery and vein. Causes for this in the field inflammation. The nerve pressures is close to the axillary vein and axillary artery. For the ultrasound guide, peripheral nerve block is more attractive technique to avoid puncture to the blood vessel because of shortness and readily available in the operative theater. The imaging can be performed in a variety of exercises, such as brachial exercise and lumbar exercise, and even all peripheral nerve block. C can use peripheral nerve block in the finger. In conclusion, neuraxial anesthesia during major orthopedic surgery combined with venous thromboembolism prophylaxis is generally safe and well tolerated, with potential benefit over general anesthesia. The risk of spinal or epidural hematoma, a rare but very serious complication, can be minimized by careful patient selection and attention to anesthetic technique. This risk is further reduced with the use of peripheral nerve blocks in place of neuraxial anesthesia. This should say, but I hope this is a starting point to the treatment with care for all. Thank you for your attention.
Thank you very much for the nice presentation.